Hey everyone, welcome back to part 85 of our explainer series, Decode Healthcare with Harshal. I'm absolutely thrilled you're here today because we're diving into one of the most dynamic, fast-paced areas of the entire CMS rulebook, Chapter 22, Codes for Special Purposes. If you're looking to lock down some of the absolute strictest compliance rules in the medical coding world, well, you're in exactly the right place. Let's get right to it.
So before we get into the heavy technical guidelines, I want you to think about this for a second. How exactly do you code a disease that literally didn't even exist yesterday? Imagine trying to categorize a brand new global crisis with yesterday's dictionary. When a sudden, completely unpredictable emergency strikes, how does the World Health Organization handle that massive influx of data using the CMS guidelines? The answer is that they need a highly adaptable, specialized section of the codebook ready to go at a moment's notice. And that, my friends, gives us Chapter 22. The U00 through U85 block is essentially the WHO's emergency sandbox. It's reserved exclusively for the provisional assignment of new diseases of uncertain etiology, or for tracking massive emergency outbreaks. This is exactly where we find the codes for unprecedented health events, like the COVID-19 pandemic, and that sudden massive rise in vaping-related lung injuries. Here is our quick roadmap for today. We'll be looking at COVID-19 confirmation, COVID-19 sequencing, the post-COVID condition, and finally, vaping-related disorders. Okay, Section 1, COVID-19 confirmation, the exception to the rule. You know, when COVID-19 hit, it completely shattered one of our most fundamental medical coding conventions. The standard inpatient rule, which I'm sure a lot of you know by heart, dictates that if a condition is documented at discharge as suspected or probable, you code it as if it exists. But under the COVID-19 rule, absolutely not. You never code suspected or probable cases. For code U071, you only code confirmed cases. If the test is inconclusive or the provider just suspects it's COVID, you only code the presenting signs and symptoms, like a cough or a fever. Let's look at the exact wording right out of the official CMS guidelines. It says, code only a confirmed diagnosis of the 2019 novel coronavirus disease, COVID-19. This is an exception to the hospital inpatient guidelines, section IH. Now, keep in mind, confirmation doesn't necessarily require a piece of paper with a positive lab test. The provider's clinical documentation clearly stating the patient has COVID-19 is perfectly sufficient. But without that definitive confirmation, U07.1 cannot go on your claim, period. Moving right along to Section 2, COVID-19 sequencing, the if-then hierarchy. Let's translate this theory into everyday practice. If a patient is admitted primarily for COVID pneumonia, U07.1 takes that principal diagnosis spot in slot number 1. The manifestation, pneumonia, follows right behind it in slot number 2. But wait, here is the major exception. If that patient is admitted for sepsis caused by COVID, the sequencing totally flips. Sepsis, code A41.9, takes slot number 1, and COVID-19 gets bumped down to slot number 2. And it's the exact same rule for obstetrical complications or transplant complications. Those conditions will always demand the primary slot over U07.1. So what happens when the diagnosis isn't immediately obvious? Let's trace the clinical logic tree. Step 1, check if the patient is symptomatic. Step 2, determine if the test is confirmed or ruled out. Step 3, dictates your code. If you've got an asymptomatic patient who was just exposed or a symptomatic patient whose test was definitively ruled out, you cannot use U07.1. Instead, you're going to assign a Z code, specifically Z20.822 for contact with and suspected exposure to COVID-19. Let me tell you, mastering this logic tree is exactly how you protect your facility from failing an audit. All right, Section 3, post-COVID condition, coding the long hauler. As we all know, the medical community quickly realized this emergency didn't just end when the virus left the body. To track these long haulers, we use code U09.9. But here's the catch. U09.9 is almost never coded all by itself. It requires specific symptom stacking. You actually have to map it alongside the specific active manifestations documented in the patient's medical chart. So for example, if a patient presents with chronic fatigue and brain fog related to a previous COVID infection, you code those specific symptoms first, and then you attach U09.9 to show the direct relationship to their history with the virus. But beware of this massive coding trap, guys. Code U09.9 should absolutely not be assigned for manifestations of an active current COVID-19 infection. It is strictly 100% reserved for long haulers who have fully cleared the initial infection. If they still have an active infection, you need to stay right in that U07.1 lane. Which brings us to Section 4, Vaping-Related Disorders, U07.0. Just like COVID-19 required immediate tracking, that sudden, terrifying spike in severe lung injuries tied to e-cigarettes triggered the WHO to activate code UO7.0. When a patient is admitted for pulmonary pathology that is directly caused by vaping, UO7.0 acts as your principal diagnosis. Doing this signals immediately to researchers and payers exactly what the root cause of the crisis really is. But just slapping U07.0 on a claim doesn't really tell the whole clinical story, does it? Similar to COVID, we have to use secondary manifestation code stacking. Once U07.0 is sitting in your primary slot, you stack the specific clinical outcomes underneath it based on the chief reason they were admitted. This might look like acute respiratory distress syndrome, which is code J80, or maybe chemical pneumonitis, code J68.0. Now, the absolutely crucial point here is knowing exactly what to bundle and what to unbundle under these CMS rules. Associated respiratory symptoms like a cough or shortness of breath, do not code those separately. They are considered inherently bundled right into the definitive vaping lung injury diagnosis. However, if the patient is experiencing gastrointestinal symptoms like diarrhea or abdominal pain due to the vaping toxicity, you absolutely do code those separately. It's exactly these fine line distinctions that ensure your claims are accurate, compliant, and ready to go. Let's take a step back for a second and look at the core philosophy of what we've covered today. Chapter 22 literally bends the standard coding rules so we can track the unknown. Whether we're overriding the suspected condition rule for COVID-19 or building these complex stacking hierarchies for vaping injuries, these special codes are vital exceptions. They ensure our healthcare data remains incredibly precise, even when the global health landscape is completely unpredictable. So we've seen how external emergencies dictate these special coding rules. But I want to leave you with a provocative thought as we wrap up today's explainer. What happens to your sequencing when the external forces aren't a virus or a vape pen, but rather blunt physical trauma, poisoning, or severe burns? How does the whole hierarchy change when a patient is rushed in after a catastrophic accident? Well, that is exactly what we are going to unpack next time. In Part 86, we will be diving deep into Chapter 19, Injury, Poisoning, and Certain Other Consequences of External Causes. We'll be covering trauma guidelines, those tricky mandatory seventh characters, and the intricate burn coding rules. Until then, take these Chapter 22 rules, apply them directly to your claim reviews today, and please don't forget to like and subscribe if you found this helpful. Thank you so much for joining me, stay focused, and I will see you in the next explainer.